Well, so first, good morning, good afternoon, depending on where you guys are. Thanks for being here. So today we're going to talk about implementing AI documentation in behavioral health. I'm going to try my best to not make this a sales pitch for AI. Um, and it's definitely not going to be an advocacy for AI to replace anything clinical. This is just an implementation case study from a rural FQHC, kind of what problem we were talking to solve, how we approached consent and risk, what clinicians were worried about, what improved, and what's kind of still, kind of requiring governance. So with that, I'm going to go ahead and kick it over to Ken for him to introduce himself.
Yeah, well, so you can see the slide there that kind of gives a summary of my background and experience. And also thanks to AI, I look like I'm on the beach when I'm in fact not on the beach. You probably already knew that. I have quite a bit of experience clinically, and really to sum all of that up, what that really means is that as because AI documentation is not just an administrative tool. It really enters into the clinical workflow. And so the clinical context has to remain central. And I think my background and experience can helps me be able to do that. And I'll kick back over to John so he can give an introduction of himself.
All right. Yeah. So I'm John. I'm the Assistant Director of Behavioral Health at Hawse Health Center. Um, like Ken, I'm a licensed independent clinical social worker. I'm also a practicing clinician. Um, as an FQHC, we work with pretty much every demographic of people. A lot of my clinical background is in EMDR and non-directive play therapy. I also come from an integrated care background, which means that I have a little bit of additional training in working with allied health professionals. Um, yeah, so that's just a brief bit about me.
Okay, so Hawse Health Center, it's a federally qualified health center, and our mission specifically to EAHAS is to provide high quality, affordable, comprehensive healthcare to all people. Uh, Being a federally qualified healthcare facility in multiple counties in West Virginia, obviously there are a lot of governance related to that because we are funded in part by federal government, which means that we have to supply documentation of things that we do. We have quality assurance measures that we have to report on. As far as behavioral health services, we have 7 clinics and 14 school-based health centers, and currently 13 behavioral health therapists. And we manage all of those school-based health centers as well as seeing people in our clinics. Hawse Health has over 250 employees. So if we can go on to the next slide. So why all this matters? So as many of you know and are probably here because you are familiar with behavioral health documentation, that it's been unsustainable for a long time. Up to 50% of clinician time is spent on documentation. And with behavioral health workforce shortages, rising burnout, all of these things lend itself to what can we do to improve and make things better. And so that's why this matters. It's also it's important to document the actual problem. And so before before talking about AI, we really need to kind of focus that. The problem is not just about notes take too long, but the real issue with documentation, it carries with it this burden due to trying to attend to your patient, to your client, having a clinical presence, all the compliance issues. It speaks to morale, or it speaks to sustainability. So if we narrowly define the problem as, simply asking AI to make note-taking faster, then we're not going to be as effective because we really need to define it more broadly and ask the question of whether technology can reduce cognitive load while preserving clinical judgment and maintaining that therapeutic relationship. So that's the problem that we really wanted to focus on more than just let's make it faster. So if we go to the next slide, we kind of see here what we call the clinical cognitive stack. We see active listening and therapeutic intervention, risk assessment, safety monitoring, treatment planning and goals, documentation requirements, compliance and regulatory standards, scheduling, billing, administrative tasks. Exhausting just saying it, much less realizing that as clinicians, all of that often is going on simultaneously. So all of that is going on often in a therapeutic session where the clinician is trying to maintain a therapeutic relationship and interaction with a patient, but they have all of this clinical stack to kind of manage, which obviously can become rather burdensome and cumbersome. If we go to the next slide, we see what's going on here is a parallel process. So clinicians document while they're actively engaged in the session, and they're trying to balance the patient needs versus the documentation burden, and they're doing that in real time. So that often results in after hours documentation. That becomes the norm, not the exception. So without the use of AI, without the use of a transcriber, then it's after the session, sometimes after the day, that, and sometimes even days before. We noted that backlogs quickly accumulate. In our practice, we saw backlogs as high as 100 rolling encounters, meaning these were counters that maybe were started, but they were not complete. And those were going on as part of this, and obviously this parallel process contributing to burnout and administrative burden. It also creates instability within the workforce, which is very problematic in rural areas where we're struggling to recruit and maintain adequate staffing. So obviously, when you're having this parallel process that's contributing to burnout, it really makes that critical that you find some way to manage that. Okay, if we can go to the next slide. So this kind of looks at what our traditional work documentation workflow would be. You have the session, you're trying to do active listening, be attentive to your patient, to your client, but you're also trying to take notes or remember things, or take enough notes that you can remember things that are important. You may be needing to write down medications. You may need to write down certain things that you want to remember. So you're trying to do that while you're actively listening to the patient. After the session, you try to reconstruct from memory or what limited notes you may or may not have been able to take during the session. Then you try to draft that note, you write a clinical documentation. Then you need to review that and check for compliance and accuracy, and then you finalize it. And so often that whole process takes you to after hours, or in some cases, even days later, when you're finally going, what did I do in that session? Trying to look at your notes, trying to remember. So it causes cognitive depletion because there's a split attention that kind of degrades the therapeutic presence. The delay in documentation is going to contribute to inaccuracy and also to compliance risk. And it makes your operations more fragile. So small staffing changes then cascade throughout the entire system because of this overload with how we've traditionally done our documentation. And I'm going to turn it over to John for our next slide.
All right. So what exactly is ambient AI? Um, it seems almost mythological. Very few people can kind of explain what it is or what it does. But I love pulling the curtain back, like kind of like in The Wizard of Oz, and it's not Skynet. It's math in a sweater vest. Um, Next slide, please. Um, so it's not a thinking clinician. It's not autonomous therapy. It's a specialized documentation tool that captures language, processes it, and drafts clinical documentation for a clinician to review. You're going to hear me bring up a lot that the clinician is in control constantly. None of this is automated without the clinician has to start it, the clinician stops it. Nothing is entered into the patient record without the clinician signing off on it. At the end of the day, kind of final say rests with the clinician. Um, Next slide, please. Okay. Um, so there's a lot of confusion kind of about like categories and um, kind of what constitutes AI or kind of the use of it here. Um, Specifically, I'm talking about ambient AI, so like Scribe, it's running in the background in the session. The biggest things that it's capturing are the therapeutic intervention, and the patient response to the therapeutic intervention. Um, it's not making any clinical decisions. Um, it's not generating anything. It is very very narrow, um, like very narrow language processing. So it's predictive text that's basically trained specifically on kind of behavioral health, and in our case, our scribe is also medical, but it's trained specifically on those things. Um, Next slide, please. All right. So, and I'm trying to rush these a little bit because I know you guys had a lot of questions, and I definitely want to like get to those at the end. Um, so, kind of clinicians aren't expected to be able to explain what a transformer is in any more than I would expect a radiologist to build an MRI machine in their garage, right? Like they don't need to be able to build it, but they do need to know enough to safely oversee the tool, identify when it might be, not giving accurate results, and to be able to explain it to patients because informed consent is really important. Um, and they don't need to know how to like train the system or um, modify it or anything like that. Um, Next slide, please. So kind of now we'll move into the actual implementation that we had. So this is kind of where the clean version of the idea meets the actual clinical workflows, patient conversations, staff anxiety, technology limitations, and all of the messy middle of any sort of organizational change. Um, a lot of AI conversations stay abstract. Our experience wasn't abstract. It involved real clinicians, real patients, real documentation requirements, and most importantly, real operational constraints. Um, we enrolled 13 clinicians over about a year and a half. As of right now, we're sitting at a little over 26,000 AI assisted encounters. Um, Use was optional. It still is optional. Um, we're in rural West Virginia. We didn't have the ability to run any sort of an isolated pilot or anything like that. Um, we kind of rolled it out with everyone and kind of let the clinicians um, get experience with it initially as a dictation aid. Um, and that was interesting because a lot of them had come from using other dictation aids that had not gone very well, that were not AI assisted. They didn't do a very good job of picking up words and things of that nature. Um, so while they were doing that, they were talking with their patients and they started working to get consent from their patients. And then once they were able to kind of feel comfortable enough with the tool and get informed consent from their patients, they began using it um, for full ambient documentation. So it's, they bring the patient back and they start recording. And then end of the session, they click end. And of course, the patient's, able to opt out at any time. Um, and it's one of those things like when I do it, my laptop and everything is all the way on the other side of the room. So it's not even, I don't even have the barrier of the notepad that I might have if I was taking notes before during a session. Um, so then that's kind of a very brief overview of our implementation. I'm going to kind of send it back to Ken here to talk about some of the clinical concerns related to the implementation.
Oh, Ken, you're on mute.
Sorry about that. Yeah, you really can't see, but in preparation for this slide, I literally like rolled up my sleeves because this was a very interesting process. Even though this slide is very good, I don't know that it completely does justice to how we were able to manage the initial clinician concerns. So if you can imagine our agency, 250 plus, we have a quality assurance day, and our whole agency comes together for a whole day of addressing various issues. On one of those days, we had a breakout session, and our behavioral health team met together to review potential ambient AI that we may be able to use. And it was during that time that we really opened this up to an interactive discussion with our clinicians. And I think this was very key to implementing it. They got to see the presentation, but then after the presentation, we had very open, candid discussion about, what do you think about this? What are your concerns about this? What are the ethical concerns about this? How could we manage the ethical concerns? So thematically, we saw, some of the themes was, well, patients won't want this. So there were some clinicians, that was, and rightfully so, that, they're saying, we're concerned about our patients not wanting this. We did find that as we rolled this out, we learned from, so to say, our mistakes. So initially, when we rolled it out, very giving much attention to informed consent, we provided them with 2 pages and an explanation of ambient AI. What we found is that patients got overwhelmed and guardians got overwhelmed with that much information. So we backed that off, and even doing it that way, 90% were still agreeing to this. 90% of the patients were saying, "Yeah, this sounds like something that I when they recognize clinicians were going to be able to be more present, more attentive." That was a key issue for them. But then after we backed off and said, wait a minute, we're giving them too much information, and we brought it back down to 1 page that was both an information and consent page, and then discussing that with them if they had any. We're now at about 99, maybe 99.5% of patients give consent. The other thing, that we saw thematically is, well, this is just going to be another burden. It's one more thing for me to do. Oh no, I've got to learn a new system. Oh no, this is going to bog me down. But we found a rapid shift after they began to actually use the scribe. Then they immediately saw a reduction in their documentation burden. And they began to utilize it more and more and begin to ask additional questions about how to improve access and how to use it more effectively. And then we also saw a theme of it won't understand our patients. Again, a very valid concern, especially here in rural West Virginia. Sometimes our dialect or we may have an accent, or there might be some cultural nuance. And that does remain a challenge, but we've found ways to help improve that. I know one of the things that I do in my sessions when I'm using ambient AI is I will sometimes, like if I'm doing a therapeutic intervention where I'm playing some sort of a therapeutic game, and there's a question and answer, I will sometimes, oh, this is a answer. This is a question that the therapist gets to answer. And then I might say, oh, this is a a question that Johnny's going to get to answer. So I can give the AI some cues. And I have been talking with our ambient AI provider about how we might be able to improve that. So that was and is a valid concern, but for the most part, it is done very well, and it's not been such a barrier that we've not been able to use it effectively. And then some clinicians were a little more skeptical, like, "Oh, this is just about productivity. You're just trying to make us increase our numbers." But when we were able to explain that this is not about increasing your productivity, this is about decreasing your stress. This is about decreasing your documentation burden. That was a much better received than if we were to try and tell them, oh, this is going to increase your productivity. If we could go to the next slide, please. So, as I mentioned, informed consent is extremely important to us in behavioral health. Most of us, whether we're a licensed professional counselor, licensed independent clinical social worker, psychologist, whatever licensure you may come from, most of us have ethical codes that talk about informed consent. And so for us, that was extremely important that they not only consented, but they were informed. They understood what they were consenting to. So patients learn about the tool before the session ever begins. We now have that as part of our intake packet, and they have the sheet that they can read and sign off on. And so we actually have written informed consent. We obtain that with all of our patients, and we do that before we have the session. We also give them the option during the session or during the intake to discuss any questions or concerns that they might have about the use of ambient AI. Some of them like to have a demonstration of it. So we are more than able to do that. We can show them how it works, how it transcribes. Our ambient AI doesn't record, it transcribes in real time, but we can show them how that transcription can then be used for notes, can be used for clinical homework assignments, can be used to help create treatment plans. Again, it's all driven by patient and clinician. So the patient is in control. They can opt in, they can opt out anytime. The clinician can turn it on or off. The clinician, of course, then reviews, edits, and attests every note. So again, it's not just, oh, it did the note, it transcribed, and now I just sign off. No, you still need to review, you need to make edits. However, the amount of time that it takes to review, edit, and attest is greatly diminished compared to what it would be if you were trying to recall all of that from memory. All right, I'm going to turn this back over to John to talk a little bit more about why implementation fails.
All right, so I would say that there are usually kind of predictable ways that this kind of implementation fails. Mandated adoption tends to destroy trust before the tool even gets a chance. Productivity framing makes clinicians hear you're not doing enough, even if leadership intends something else. Skipping the messy kind of middle of actual implementation ignores the fact that workflows have to be changed in real time. And implementation often reveals friction points that you didn't know existed. Another thing that I didn't put a whole lot of thought into until we were talking with somebody from another agency at the Becker's conference, and they were describing how much difficulty they were having getting a note template that works for both a psychiatrist and for a therapist. And the idea that they could customize that within their software they were using was completely mind-blowing to them, because that's an issue that we had never had because we invested heavily into role-based and modality-based templates early on. Next slide, please. So why intent matters. Clinicians are very, very good at being able to determine when something is being done for them versus done to them. Um, so a productivity first rollout, is being driven by see more patients. A clinician first rollout is being driven by reducing the burden and to um, hopefully include morale, quality, and patient care. Um, there have been we've observed benefits to all of these things. We also observed a productivity increase, which I'll get into later. Um, but ultimately, the biggest thing was trying to stop the bleeding, so to speak, with documentation burden and the clinicians. Um, and kind of showing that you're trying to both help the clinicians uh, reduce the burden of this thing that everyone kind of agrees is one of the worst parts of healthcare, documentation and administrative load, um, is one of those things that's going to kind of help determine resistance or buy-in. Um, if the clinician feels like it's something that is either um, harmful to clinicians or harmful to patients, they're going to be against it. Um, Understandably so. Next slide, please. So kind of before AI, I'm cautious to not attribute all of the increases to AI. So this is what we had been doing before AI to address the issue of documentation. We had clear documentation standards were established. We were sending reminders for open notes every week, regular check-ins with providers to see what the identified barriers were, what we could do to address them, kind of where we could minimize the friction points. We saw some benefit, but we hit plateau. We still had um, some clinicians who were kind of lagging behind. And uh, with us being in schools, a lot of our clinicians will prioritize seeing patients over completing documentation because it's a captive audience. They're at the school, they're going to see kids as many as they can while they're there because that's the only opportunity their kids are going to have to get any sort of therapeutic intervention. So they end up prioritizing that, and at the end of the day they've got 13 notes to do. And then another layer of like kind of all of that is we had a lot of administrative involvement with trying to address this, which has freed up time for other things. Next slide. Again, this is the rollout strategy. The first phase was about a month of using it as a dictation aid, and then kind of 1 or 2 months for consent building. I would say probably by about 6 months, all the clinicians were using it with the majority of their patients. And kind of like as Ken said, right now I think we're definitely at over 99% of patients opting in. The patients that are unwilling to opt in are also our patients who will not opt into telehealth. If they could avoid an EHR, they would. And they're just sort of inherently distrusting of technology, which is, I'm sure, not uncommon. So in the next slide, we're going to move into governance. It really is the Wild West. When we started looking into this like 2 years ago, there were not a ton of rules or regulations. I think we had started implementing this 6 months before our our uh, professional before the NASW had even put out kind of guidelines on what to look for. So early on, um, our focus was heavily on privacy and compliance with HIPAA, um, and the fact that like any sort of audio capture, even though it's not recording, it is transcribing. Um, it does require careful consent and data handling. Um, the regulatory landscape is still evolving. Um, we also had a lot of technical constraints that are specific to our agency, but there are probably some other agencies that would be dealing with this. Um, as of right now, the software that we use is browser based. Well, it's cloud based, but it runs in the browser, which can utilize a great deal of RAM, which can cause Chrome to crash, which is a terrible experience to have happen during a therapy session if you're doing like video. Um, and then, of course, VPNs and all of the other things that would happen when we're going to satellite sites, driver updates, things of that nature. Next slide. All right. The outcomes and data, what we observed, correlation is not equal to causation. Um, so before we had implemented ambient AI, our same day completion rate was about 35%. Not the worst, but far from like where we want it to be. Um, as of, I believe I was using the data through March of this year, our same day completion rate is now at around 55%. Some clinicians are significantly higher, some are like a little bit lower. But I think the lowest same day completion rate that any of our clinicians have is like high 40s, just under 50%. And then within 72 hours, we're having 85% of documentation complete. And that's including for psychosocial evaluations, which traditionally are a bit more documentation intensive and require more clinician involvement to complete. Next slide. So as I kind of touched on before, prior to this, our highest backlog clinician was sitting at pretty consistently about 100 encounters. Um, so notes are getting completed much closer to real time. Obviously, reduced parallel processing during sessions. But one of the things that's been really interesting is there's been a huge narrowing in performance across clinicians, both in number of like encounters that they're seeing per month and timeliness of documentation, which is not something that we had really anticipated at all. Next slide, please. So workflow and throughput. This is one of those things that was kind of hard to quantify because, and this is another thing that has happened with this that we weren't expecting. Because we've implemented this, we've developed some increased operational slack, for lack of any sort of better term. Every system out there has actual clinicians that work in it who have actual lives, who have actual things come up in their lives. So we didn't have the same number of clinicians kind of throughout the trial. So, or not the trial, throughout the implementation. So this is kind of based on the average number of encounters per full-time employee. Mentioning the operational slack, we In the last year and a half, we had one clinician out for several months because they had to have emergency open heart surgery. We had another clinician out on maternity leave, um, and several other things. And what was interesting is because the other clinicians were less burdened with documentation and felt kind of um, not spread as thin, they were more easily able to kind of absorb that clinician's patients until they got back. Which means that like patient access was preserved and they were able to continue getting, uh, you know, some therapeutic treatment, even though it was not with their primary therapist until their primary therapist had returned. It was extremely helpful to our folks who kind of have more severe levels of behavioral health problems and behavioral health disorders. Um, One of the big things with kind of the throughput is we didn't set out with a goal for productivity, and I would really consider this to be something that should be understood as a downstream effect of sustainability, not as a primary justification for the tool. Um, would think that this would be an indication that um, clinicians are able to see more patients because they are less stressed and are able to um, kind of work without the level of cognitive load that they were previously. With that, I'm going to send it back over to Ken to talk about kind of some of the clinician experience.
Yeah, I did. As we talk about the clinician experience, I did also want to highlight the fact that, the documentation and the burdensome of it. So at Hawse Health Center, we really would like the note to be completed right after the session. Then the next, target is by the end of the day, and then the next target 24 hours. But kind of the absolute deadline, which is kind of dictated to us by payer sources, is within 72 hours. So as you can see, that is very much a very cumbersome burden. So the clinician experience, initially, there's some skepticism, there's some resistance. Within that first week, we begin to see some first use and an immediate burden reduction starts to be felt. Um, Consistent reports of decreased stress and narrowing of performance gaps across clinicians. Uh, I always hesitate to share this, but I think it does help maybe kind of give a window into clinician experience. So for myself, when I began to use ambient AI and use it as a scribe, I've always been a clinician who is able to get my notes completed in a timely manner. I don't know that ambient AI necessarily helped me to be able to do it quicker, but what it did help me do was to use less brain power for the note and more brain power in the session. In other words, I was able to be more present. And so early on, when I'm using ambient AI, having followed, all these steps, informed consent, agreement from guardians and from patients. So I'm using ambient AI, and we're able with our tool to kind of tailor if it's a cognitive behavioral therapy session, if it's a person-centered session, if it's reality therapy, if it's trauma-focused cognitive behavioral therapy, if it's EMDR. So we have various templates that we can use depending on which modality. So it really does help the clinician to focus, like what is going to be the modality that I'm going to use. So this goes to clinician experience. So I'm doing a session. I have all the consents. Ambient AI is in the background. patient doesn't really even know that it's going on in the room other than the consent, but there's no visible thing that says it's just running in the background. And so it transcribes for me and then creates a note. And this is a little sappy, but honestly, what happened is I was reviewing the note for accuracy, and I had a very emotional response to it in the sense of I was taken aback. I was like, wow, like I did that in a session. Like I'm actually making an impact. I'm actually using evidence-based interventions, and the patient is responding. And the ambient AI documented in more detail than I probably would have if I would have trying to take notes and just recall from my own memory. So that experience as a clinician was very empowering, and it was like, wow, I like this ambient AI because I was able to fully attend to the patient and that interaction and get a note that really captured the clinical interventions and responses that took place in that. So there's just an immediate reduction in the documentation burden. We see that happening. The stress level decreases. There's more, as I just illustrated, more presence with the patients, less split attention. And now notes are being completed closer to real time rather than so many notes being completed after hours or days later when memory recall may not be at its best. So if we could go to the next slide, please. So now we're looking here at staffing stability implications. Well, obviously, lower after hours documentation, clinicians are liking that. They're like, wow, I'm not spending as much time after hours. I'm not having to do this at home. I'm not having to stay at the office so late. And obviously that then adds to this decreased clinician stress. They're feeling less stressed because I actually get to leave at 4:30 today and all my notes are done. And they leave feeling much less stress. Obviously, that's a more sustainable workload, both in terms of retention, but also in terms of each clinician feeling like, oh, this is doable. And then we see this better work-life balance. So improved retention potential, greater operational resilience, and maintain output even when the staff is reduced. These were all some of the staffing stability implications that we were seeing. Okay, back to John.
All right. So kind of into the most boring part of this, risks, bias, and governance. We're optimistic, but we're not unserious. AI documentation can help, but it also introduces a ton of like real serious risk. Behavioral health is sensitive, subjective, and relational. A tool to draft notes from therapeutic conversations must be governed carefully. The right posture is not hype and it's also not panic. It's grounded optimism with careful oversight. Naturally, there were things that did not go perfectly. It will never be flawless. It went as minimally painfully as possible, I would say. A lot of the big things that we saw come up repeatedly were attribution errors. And pronoun errors, not so much in terms of like gendered pronouns, but more in terms of like plurality mistakes. So like plural they versus singular they. And some ESL challenges. I saw a question about like people who had English as a secondary language or a tertiary or not their primary language. And it's fairly good. The software that we use allows you to select what languages are being spoken. Even when we use a translation, like a medically approved translation service, the note will include quotes that are in the native language and quotes that are in English. I don't have enough data to say like a definitive answer of how good it does, but in the handful that I've used, it's seemed to work fairly well. we we practice in a shockingly diverse community for rural West Virginia. Um, so we do have a lot of people who speak English as not their primary language, um, but it doesn't seem to have as much issue with picking out words through accents as it does um, differentiating the actual speakers. I know one of the big things that happens is if you're um, talking with a patient and they're describing an issue that they're having with their family, and the family member that they're talking about is exhibiting various problems. Occasionally, it will identify those problems as being the patient's, not their family members. Um, and we live in an area where a lot of folks are um, we work with a lot of kids, so they're living in kind of non-traditional family homes. So it might misconstrue uh, cousins as siblings, or grandparents as parents, or various other things. Um, so hallucinations are limited but present. Um, they're generally kind of the things that I just mentioned, a lot of speaker attribution error. Um, I've not noticed it to make anything up completely. Doesn't mean it's not possible. I'm sure it probably can and does happen. I've not had that personally happen. I usually just get kind of incorrect attribution, and it will assume relationships. I should say that. Um, so I was doing one this morning, and it referred to the patient's uh, aunt as their stepmother. Um, so like catching things like that. Um, the way that we generally addressed it. Oh, all right. I'm going to rush to this really quick so we can get to the other questions. Um, the sentiment analysis is very strong. It does skew towards safety, so it's going to over identify risk. Anyone who works with like uh, young adults, teens, sometimes they can kind of flippantly use phrases suggesting that they might be suicidal. They don't mean that, but it's going to identify it. Um, Next slide, please. Uh, so dialect and cultural nuance. So not everyone speaks perfect English, especially here. Um, Regional expressions carry clinical meaning that AI may misprocess. We have a lot of evidence that AI is biased. I mean, it's trained on us, so of course it's biased. Um, there is documented bias with like African American vernacular English in all models. There's limited research on other models, but it seems to be, since it's transcript based, um, that it is anything that is not like perfect English, or like standard English, standard American English. Um, so that's something to be mindful of it moving forward. Um, Clinician review is absolutely essential. The only way that we could figure out addressing these issues is through clinical oversight. Um, I don't know that there are engineering controls that we can do to eliminate bias or eliminate hallucinations. We do the best that we can, but the clinician still has to review it and has to sign off on it and attest that, this is the actual note. Next slide, please. Yeah, over reliance and oversight, risk of complacency, de-skilling, getting overly confident in it and just kind of signing off, not appropriately reviewing it. So the mandatory clinician review and attestation, informed patient consent, and we do, of course, do chart reviews and audit the notes pretty consistently. And that's one of the things that we've used to ensure that it is accurately catching the information that we need as far as like intervention response and so forth. Next slide. And I think this goes back to Ken.
Yeah, where I see we're so much running out of time, and there's so much more I'd like to say. I noticed one of the questions was regard to, reading notes from ambient AI that they felt like you could easily spot that it's AI. Interestingly, with the tool that we use, AI has been learning from me. I tell it how to document, and as I've used it more, it now reads like the way that I document. And it's really using it as a scribe, just like you would a human scribe that types something for you, and then you're not pleased with it, you give it back and say, no, that's not how I like it. So we have the ability to make prompts and tell the AI to redo it, or to redo it this way, or do it in narrative form, or do it in bullet points, or follow SOAP process, or do it as a DAP. So we have those abilities to do that. The other thing I want to highlight here, and I'll try to do this quickly, is the therapeutic relationship is still paramount. Without an adequate therapeutic relationship, your clients, patients are not going to feel comfortable with this. A while back, I had a patient who had seen another clinician, and in that clinician's office, they had cameras that had been disabled. But the patient felt that those cameras were recording all of their sessions, and they based that on the fact that their parents seemed to always know whatever they talked about in sessions. So when this patient came to me, they were very much concerned about privacy, and and trust was a big issue. I occasionally do online sessions, so I have videos sometimes. One day left a camera after having worked with the patient for a while, left the camera on my laptop, and he noticed it. I apologized to him, and immediately removed it. And his response to me was, "Oh, I don't care if you video me. I don't care if you record me." I said, "Wait a minute, you were upset with your previous therapist." He said, "But I trust you." And I think that's very key. If you're going to implement ambient AI, be transparent, get informed consent, build off of your therapeutic relationship. Do not allow the ambient AI to wag you, but you be in control, and ultimately allow your patients to be in control. We can go to the next slide, or I know we're maybe out of time. I don't know.
Okay. All right. I'm going to go super quick, and I'm just going to try to touch on the part two stuff. The biggest thing is conduct your vendor due diligence. The same requirements are going to apply to any sort of ambient AI as would apply to EHRs, clearinghouses, anything else that you would be using. So the biggest things that you would need to know, I'm trying to look at my notes really quickly. So it's, how is the data being stored? What is it being used for? Who has access to it? How long is it retained? And the answers that you want are, you want that the data is encrypted in transmission and at rest. Ideally, well, servers need to be in your appropriate locale. So for us, it would be in the US. The data needs to have role-based access for anyone not in your health system, meaning that people can't just access it through the vendor. It needs to be ideally not used for any sort of training, whether it be de-identified or not. That's the way that we've gotten around the concerns about re-identifying data being used. And then of course, you need to have your appropriate either BAA with the Part 2 addendum or the separate, was it QOSA, the Qualified Service Organization Agreement. Just a little tip, if the US lags behind most of a lot of the rest of the world with regards to safeguards on AI in healthcare, if you are working with a company who has any sort of certifications in the EU, especially, uh, the EU and the UK both have fairly robust restrictions. Um, so if they meet those requirements, they probably meet the requirements of both HIPAA and Part 2, but you still need to make sure that they have the appropriate BAA or the appropriate qualified service agreement for the US. I hope I answered that quickly enough. Next slide. SUD treatment, same thing. Do your due diligence, focus on the workflow, use the same criteria you're using to determine your EHR and your clearinghouses and billing provider if you are. Next slide, please. Yeah, again, same considerations apply to EHR vendors, transcript, billing, and clearinghouses. So next slide. Again, Part 2, it comes from a good place of wanting to protect patients. And if you are using software that is compliant with that, you are definitely able to use it with SUD treatment. Yeah. Next slide. Oh yeah, that's the thing that I was looking for. Who can access the patient information? How long is the data retained? Where is it stored? Is it encrypted? Are audit logs available? That's an important one. Is the patient information used for model training? And is a BAA and or QSOA in place? If it's cool, I will send out, I have a checklist that you guys can use for looking at vendors. If it's cool, I can get that to Wes and or Sierra and they can get it out. And then I'll do my best to answer any other questions that you guys have. I think that's all, more or less all that I have. I know we're running out of time here. So next slide. Or yeah. Again, the goal is not replacing clinicians. It's helping it be sustainable and improving services for the patients as well as improving work for the clinicians. And yeah, that's it. Thanks for having us. There's contact info. And I will get this stuff that I have sent out to Wes. And yeah.